Well, thanks so much for having me. I want to make sure in the back row, can you guys hear me? Yep. Okay, good. I'm not going to use the mic. But this was a long time coming. I was supposed to come earlier. My colleague, Tom Campbell, Dr. Campbell spoke to you, I think, earlier in the semester. He and I work very closely together on this rehabilitation unit, and so probably some of the things that I talk about may overlap a little bit with some of the things that he discussed. But I thought I might also pull in a few other things, but I might ask for your guidance a little bit on keeping me relevant to what is most useful to you all. I do want to say that what I'm going to be talking about tonight is based on my experience working with veterans at the VA, most of whom, as you heard, are people who have been in the wars in Iraq and Afghanistan, because I've been working in rehabilitation, so people who've been recently injured, but also have worked with people from Vietnam era and also Desert Storm, and then people who were in the military at times when there was no immediate conflict going on. And so I do want to just preface my comments by saying that these are not necessarily the opinions of the VA or the U.S. government that I'm going to be talking about tonight. But I wanted to check in with you all. Are any of you veterans in this group? How about family members? Any of you have family members who are veterans? A few of you. What eras, if you don't mind me asking? Anybody shout out? So some Vietnam. Afghanistan. Okay, so family members who are in the current conflict. Any others? Pardon? Afghanistan and Iraq. Okay, so how much interaction are you having with people from Afghanistan and Iraq conflicts? I mean, it sounds like you have some family members. Some of you not, are shaking your head. I was just a little bit curious of how much you might already know from your personal experience. But feel free, as I'm talking, if you have another perspective or you've heard something different, I mean, please feel free to put that out there, because I'm hoping this will be somewhat of a discussion, not just me talking. Here's what I was thinking about talking about, but this is where I might get your input. I thought I might start off by talking a little bit about sort of a theoretical stage model for families when someone is deployed, because I thought it might be a little bit different, and also because in my work I work quite a bit with families of people who have been injured in Iraq and Afghanistan. And so sort of what is the psychological aftermath also for the family unit as well as for the individual. So, I plan to talk about that, but I might keep that short. Then I think I will spend more time focusing a little bit on combat stress, PTSD. You guys probably have read about it with other terminology. We were talking earlier about shell shock, and the effect that can have on people, at least from my perspective, seeing it from the perspective of mental health and being a psychologist. And then I have a video that I'd like to show you that was made by the Marines, where you could hear directly from some veterans in terms of some of their experience. And these were, I believe, were in Iraq. And then I'm hoping to make, because my job is to work with people and try to help them become better, but I wanted to make at least a quick comment on some treatment. And then, see how this fits with what you have been reading and studying. And so have some opportunity for some discussion around that. How does that sound? Is there anything you want to guide me more to or more away from? Anybody?
I think especially that number 2, and on down.
Okay. Okay. What I might do is I might just give you a really quick overview on the family stuff and then move into the rest. So I'm going to, just to provide some context, this may be a study that you have heard about, but just to give you some idea of the effect of, I guess, some mental health issues for people in the more current conflict. There was a big telephone study, big screening done of about 2,000 people who had been deployed. And these were people mainly deployed to Iraq, because this was back in 2007. Hadn't really ramped up in Afghanistan yet. And basically what was found in this study was that about 14% were screening positive for post-traumatic stress disorder, hitting all the criteria for that. And about another 14% were also screening positive for depression. And then about 1 in 5 people had a probable traumatic brain injury. And I know you heard a lot about that from Dr. Campbell. These were probably people who had more of a concussion versus a very serious brain injury. But what we know is that there seems to be a kind of an interplay between people who've had a concussion or some other kind of even more serious brain injury and people who seem to develop PTSD. We don't completely understand why that is, why that seems to make people more susceptible. But that is something that is under a lot of study. There's a lot of research going on with that right now. But what we don't know is how many people answered these screening questions in a protected manner. They were still in the military potentially. They may not have wanted to kind of fess up to some of the symptoms that they might have been having. So we are anticipating that probably those numbers are a lot higher. The other thing is we don't know really in terms of a number how many people were struggling from adjustment-related problems that didn't rise to a serious mental health disorder. What I can tell you from my experience, I mean, of course, I'm working with people who come in who are injured or seeking treatment, but you know, a very large number of people have some kind of adjustment-related issue, whether or not it becomes a mental health problem. More studies are going on, and several other similar studies have showed pretty similar numbers, so this is kind of what we're looking at. I wanted to mention this is kind of something a little bit different, but that there is this approach that Howard Kudler, who is a psychiatrist in the VA, has really been trying to promote this idea of working with veterans through this public health approach, so that it would be a way to really proactively address anybody who is coming back from being deployed or just anybody who's been in the military, to try to provide more early intervention and education to not only families and service members themselves, but to communities, to really try to help veterans meet them where they live and not necessarily expect them to always have to go to the VA and try to get through all the red tape to get help and treatment. And so he's really trying to propose that as a society we really need to be looking at not only our medical helpers through the VA, but also in private, you know, hospitals and clinics and so forth. But also let's look to churches and the chaplaincy and to other community organizations, families and so forth who provide support. So we're really trying to address this in a more holistic way. And really emphasizing the idea of wellness over this idea maybe more of pathology. And so I put this in here because I thought it was interesting that there's this approach that's kind of being tried, and I don't know how exactly successful it is, but how might this be different from other eras that you've read about in terms of how veterans may have been treated and what was the approach to trying to help them? So that's just kind of a rhetorical question. I will say certainly for people who have been in the Vietnam conflict, this was not the approach that they felt like was used when they came back from Vietnam. Rather, it was much more of a, you know, if you have problems, you should go deal with it. You know, maybe the VA can help you, maybe not, but we're not really dealing with that as a society. At least that has been what a lot of veterans have expressed. Any comments about that, or differing viewpoints, or Civil War, World War I? Probably different from Vietnam, too.
Yeah, but there was nothing since it didn't exist.
Yeah.
Yeah, there was very, very little. And even, not even an awareness that there might be a problem, and being reaccepted into a very different world. Yeah. Very different.
Yeah, and I guess the VAs didn't even exist until after World War II. I'm thinking that the VAs kind of coalesced around World War II and really kind of got their name, in some ways in the negative way, because of some of the ways that Vietnam veterans did not get services. And so I think that, you know, there's definitely a ways to go. So I had mentioned that I wanted to spend a little bit of time focusing on families, and part of that is personal because, like I said, I work a lot with families, and I have seen the impact that deployment and injuries and PTSD has had on family members. And at the same time, I've also seen how family members can be so instrumental in helping the service member who may have PTSD or may have other kinds of adjustment issues. And so there's such an interrelationship. So when we think about the aftermath, the psychological aftermath of war, I don't think it's really just the individuals who went to war who are affected, but rather, you know, the families, and that bridges out the society. Some of you are family members yourself and can probably speak to this. So I wanted to just mention this proposed emotional cycle of development. Some psychiatrists actually proposed this more in relation to when people started having longer deployments. And this was around the Bosnian conflict, another conflict that we don't hear a lot about that was prior to Iraq and Afghanistan. But people started being deployed for like 6 months at a time. And so they were looking at, well, what is really the impact on family members? And so through interviews and anecdotal information and surveys and talking with families, they kind of came up with this approach. And so the idea here is that although families are different, not all of them are alike, all families are unique, there's going to be a lot of variability. If families can kind of understand what some of these issues are related to these different phases of deployment, they are going to probably have better outcomes, have better adjustment, and have fewer mental health issues. So I don't want to belabor this too much, but I'm just going to run through these real quickly. The first stage is this concept of pre-deployment. So you're in a family, so if you guys wouldn't mind for a moment thinking about, maybe you are a family member and your partner is going to go off and be deployed, just to get you in that mindset for a second. And so the idea here is that we don't know how long this is. Sometimes this is a month, sometimes people know, you know, quite a bit of time in advance, sometimes they don't know very long in advance at all. But the idea is that there's really this sense of anticipation of loss, that this person is going to be leaving, and also a real sense of denial that this is really going to happen. And so, and you may have heard about this, and this is kind of a common phenomenon, I think also when people go off to college, although certainly it's different than going off to war. But that idea of wanting things to be really perfect before you go with your family or with your friends before you leave, and sometimes maybe having some arguments, there might be some tension, you know, there's sort of this build-up, this anticipation to something that's going to be very, very different. And so a lot of times this is an opportunity to kind of get your affairs in order for family members and the service member who's leaving, but also it can be a time when the service member is actually already training and isn't even there very much. And so it can be a very challenging time for families. Now, of course, for people to have a more positive outcome is if they can kind of communicate about these things even before they leave. You know, what are going to be the ways that we're going to communicate while you're deployed? How much communication are we going to have? What is our plan going to be for the child rearing if there are children? You know, who is going to be responsible for various things like paying the bills, mortgage, that kind of thing. So then the next stage is deployment. And so, of course, now the person has left. This is early deployment. It seems like if you look at an aggregate, families initially have kind of a feeling, those that are left at home are feeling kind of overwhelmed and disoriented. They may have some anger that certain things didn't get done before the service member left. They may have feelings of being sad, numb, might have difficulty sleeping. But at the same time, even though this person is gone, and this might be really specific to this conflict, they have the ability to be in contact, particularly usually early in a deployment. And you hear a lot of people talking about this, that You know, there's the ability to text, to Skype, to email, to even sometimes have phone calls. And so sometimes some of those issues from home start bleeding over for the person who is, you know, now deployed, and they may be getting phone calls about the car that broke down, or, you know, so-and-so's having trouble in 2nd grade, or, you know, I don't know where to find such and such, where did you put it? I mean, all kinds of things like that start being transmitted into the deployment arena. Generally, over time, people on the home front start to get more confidence, they feel independent, things are working okay, they have support, oftentimes from family readiness groups. I don't know if you guys have talked too much about the difference between people who may have they're deployed but they were part of the reserves or the guard versus if they were active duty, because there tends to be a lot of difference in terms of the level of support that these individuals have, with those in active duty having a pretty big community of support while the service member is deployed. So again, you still have rapid communication possibilities. You know, both service members and family members have talked to me many times about just concern about rumors, you know, that they're hearing about from other people who are on the home front, or service members are hearing it from other people. So there's really a lot of challenges of this everyday living that you may not even be thinking about when somebody is in combat. So now, person's coming back. And so this is kind of the redeployment phase. While for the most part, I think most people would say there's a lot of anticipation around this, there's also can be some apprehension and worry. I was meeting with a veteran just the other day, a woman who had been deployed previously. She is now out of the Army, but her husband was deployed, and he was on his 3rd deployment. And she said while he was deployed, they actually had communicated quite a bit and had really shored up their marriage, she felt like. But she felt very concerned about, well, what's it going to be like when he comes back? Who is he going to be? He's already been diagnosed with PTSD. How is he going to really respond to her and to her child? So, you know, it's those kinds of things that really have a big impact on this time frame. So now the person is back, and a lot of times the question is, you know, who is this person? The service member has changed based on his experience. The people on the home front have changed as well. A lot of times there's a honeymoon period. Sometimes that has a fair amount of substance use, alcohol. During that time, sometimes people come home, they're excited, they want to party. And so that's kind of a few weeks for a lot of service members where they might have, you know, a very good reception coming home. But sometimes for both the family member and the service member, there's a lot of question around roles. Now there's this opportunity to reintegrate back into the family. Well, who's going to be more the disciplinarian? Who is going to be taking care of the children? Who is going to be doing whatever? And so there's this whole process of reintegration that goes on generally for a while after somebody is home. What has happened is with the current conflicts, there have been some attempts to actually revise that model that I just told you, and they've made it a little bit more complex, found that longer and longer deployments have actually created more difficulties. Just to real quickly show you that second one, detachment and withdrawal. A lot of times family members, you know, it's the 2nd, 3rd, 4th deployment, and it's easier to just kind of feel numb, and it's very hard to kind of get yourself up for yet another deployment. And then lastly, that reintegration and stabilization. For a lot of times people are coming back before they really even have a chance to get back into their roles. Here comes another deployment. I have a girlfriend actually whose husband was going to be coming back from I think it was his 4th deployment. And she was very excited about that. She was talking about plans that they had, but she already knew that he was going to be deployed again, like within 6 months. And so she was preparing for that as well. And so a concern that has been expressed out there in terms of adjustment for service members and families is that they never really get a chance to completely adjust before they start up this whole cycle again. So there are these different challenges that are facing the families, and then the service member themselves is bringing home some challenging situations, some challenging, you know, experiences. So we know that they've spent, let's say they've spent 6, 9, or 12 months on constant alert. There may have been in Iraq and Afghanistan, there's more potential of firefights, IEDs, roadside bombs, suicide bombers. In other conflicts, you know, you can imagine other ways that the wars were fought that may have contributed to the same concept of hypervigilance, kind of feeling this need and desire really for this adrenaline rush because you become so used to that. Also, service members typically have prolonged periods of disrupted sleep patterns, and so they may be having a lot of difficulty when they come home in terms of irritability, not being able to get back into a sleep cycle. Sometimes they really have, you know, struggle with just taking care of children again, feeling very like, you know, they're off their sleep cycle, and that this makes that very difficult for them. Also, service members have been in a product-depleted environment, and sometimes they can feel extremely overwhelmed by our more consumer-oriented environment. How many of you saw The Hurt Locker? Several of you, yeah. And you know, you might remember that scene where the main character comes home and he's in the grocery store and he's just kind of overwhelmed by all the canned goods and all the brands. And you know, he's already thinking about, you know, how do I fit back into this? And, you know, what happens? He ends up getting deployed again. Another issue is that the service member has been consumed with life or death situations, sometimes on a daily basis. And a lot of service members, I think, and I've heard certainly a lot of this, find it really challenging to then come back to what may seem like very mundane issues that are in their life in the news. I think it was 2 years ago now, I was working with some guys on our rehab unit who were just irate and extremely bothered that there was so much in the news about Tiger Woods and his affair that he had had, or affairs, and that there was so much media coverage of this, and there wasn't media coverage of what was going on in Afghanistan. And they had buddies back there who were dying, and nobody seemed to care. And so this was just really, they had a real challenge in wrapping their brain around what our culture seemed to care about. So I think right now what I'm going to do is we're kind of shifting more into the perspective of the service member. I'd like to show you a brief clip that was put out by the Marines. This is, I think, overall this is a video that is trying to show that the Marines are really trying to encourage service members to ask for help, and for the whole community to kind of rally around each other and to try to help people who are struggling with some of these aftermath of war issues to get some help and improve their lives. And so this is just going to be a little clip. You'll hear from a few Marines and also from some of the people who are working with these individuals. What do I need to do? Can I just click on it? Do I just click here?
Yeah, try that. People are changed by wartime experience. Some certainly more than others.
We just don't have our picture.
As good as the Marines who'd gone before them. People are changed by wartime experience. Some certainly more than others. Certainly some Marines and sailors will experience a higher level of intensity than others. But I think it changes us all. People get hurt. People get killed. Sometimes there's no rationale or no obvious reason as to why one person dies and another person walks on. So I think you have to contemplate your mortality at some point in time.
The relationships they had with one another were not just important, but everything. It superseded anything else that they were dealing with. They have the unit cohesion or the sense of togetherness that manages to give them strength even in very difficult situations. In other situations, that's really difficult because if they lose a brother or a sister out there, it is a level of devastation unlike anything I'd ever seen before. I think the grief of that loss is so intense and continues to be. It was out there and continues to be in my work now. It hasn't changed, it's the same. When I came home from Iraq, I know I was not myself. I cried when things weren't sad. I couldn't cry when they were sad. I felt like I was sort of upside down. I couldn't sleep and had pretty disturbing dreams and crazy images I couldn't get out of my head. So, for the first time as a psychologist, I actually really experienced some of these symptoms that my patients tell me about.
The Marine and the sailor corpsman mentality is to just, you have to keep going. You have to keep that mission on track. And you have to do what you have to do in order to complete that mission, in order to take care of your Marines, in order to get the job done.
One of the ways that we dealt with a lot of things that were going on over there was we kind of compartmentalized everything. Issues going on with our families, we kind of put aside. Certain feelings we had, we definitely had to put those aside until we could get our missions done. And so very, very much we had to put blinders on.
Because if you don't, then you're just going to be thinking about all the stuff that you had to see or had to do, and it'll affect your mission, and it might affect other people who are with you. So you can't dwell on it while you're there because it's not healthy and safe for anyone.
We compartmentalize very well when we have to get the job done. And we have to do this. This is a really logical thing that human beings do when they've been through something traumatic. They put it away. They finish the job. And then it's much later that they might experience some of the complications from the fact that they avoided dealing with it.
You just act differently. You're a different person when you're in combat and called to do different things and very difficult things. So you have to keep your eyes on the prize and just keep going and stay on those convoys and stay on those missions because that's what's going to get you back home alive.
But there's really no way around that. We have to avoid dealing with it at the time. We don't have time to stop.
It's not new. I mean, if you study the Civil War, there were experiences that were had there by the veterans of the war that impacted them in ways until they went to their grave. The veterans of World War II, you know, the most common thing we say is that they don't like to talk about it. Well, my view is perhaps, and my father was one of those, my view is perhaps that's how they deal with it. Because I think regardless of the war, probably regardless of the nation, combat veterans are going to have this experience. They're going to have those memories. They're going to have those flashbacks. They're going to have these experiences that cause you to lose sleep, do some strange things, and otherwise just not be yourself. So it is a natural human emotion.
War is war. And so you cannot go through this experience without being changed. One of my personal problems with this is that it's hard to communicate. Not only does it change you, it creates a very difficult circumstance to explain to others. And it can at times feel isolating when you come out of this because you cannot explain it to others. But it is simply one of the manifestations of something that is so emotionally compelling as you go in through an experience like this that leaves you changed forever.
What most people don't realize is that when you go through an intensely stressful experience, such as engaging in combat, the brain and the body respond in a very intense physiological way. Your stress alarm system is activated, which floods the body with adrenaline, norepinephrine, and cortisol. These hormones help you to deal with the threat. It increases blood sugar level and oxygen throughout the body. but they also affect different regions of the brain. So it's a very intense physiological event. And so many people feel like they shouldn't have any response to a stressor. They shouldn't have symptoms. They see that as a sign of weakness. But in fact, you can't control what your body and brain does during a really traumatic or stressful event.
Combat changes everyone. It doesn't matter who you are or what you did. The experience will change you. The question is how. So I think that as I help patients deal with post-combat trauma now, that's part of my job, is to help them figure out how they were changed and how sometimes that change can be in the form of damage or a negative effect, and other times it can be positive. It can be post-trauma growth, if you will. The ability to make you into something stronger. And I believe everyone is affected somehow, but it will look different from person to person.
I wasn't sleeping at all, you know, like I would just do around the clock.
When I would try to go to sleep, I wake up like every 45 minutes to an hour. And just like every hour was the same thing. Because I don't know if it was because of the weird dreams I was having, because I was having some weird, crazy dreams that I never had before.
Common reactions to combat stress are feeling more anxious or irritable, starting to feel down, trouble sleeping, feeling kind of numb or detached, withdrawing from buddies, intrusive memories or nightmares of some combat experiences. So all of these are common responses to a severely stressful situation. And most people will experience them for at least a few days after a really serious event. If, however, the symptoms persist for more than a couple of weeks, it's really important that they go and talk to their buddies or superior officer to make sure that they get some help.
Both times when I came back, I didn't feel safe in my own house. I didn't feel safe really anywhere.
I get a lot more aggressive now than I used to.
Miscommunication, instead of it just being a miscommunication, blows up into something much more. We almost start a physical fight over it.
When you get back home, definitely, it's a big shocker. You know, things are not the same anymore, and the rush is not there anymore, and you start thinking about the things you did there and start analyzing some of the stuff that happened and the friends you lost and the people that got hurt in the way, and that's when you start having problems and you start thinking about why am I feeling like this?
You would think that coming home would be the easy part, but for many people it's not. It's actually a really difficult part. They find themselves having a lot of trouble transitioning to the pace of civilian life, to the people, and especially those that don't understand what they might have just been through. For sort of the triviality of certain parts of life, things that people worry about here feel really trivial when you've just come out of the combat zone.
So I think I'm going to pause that there and just see if you have any reactions to that or any questions before I go on. You guys, anything? I think what I'm going to do then is just take this a little bit further and talk a little bit more about post-traumatic stress disorder. The military is using more of the term of chronic stress. I've also heard people talk about post-traumatic stress. They don't want to put the D on there because they feel like in some ways, as this says here, what is going on for a lot of people is really a normal reaction to abnormal events. And so really post-traumatic stress disorder is simply an after-trauma anxiety reaction. And so what I am going to do is talk about some of the symptoms and hopefully be able to give you some examples, taking you through the DSM, which is the manual that we use to make diagnoses. But I want to really stress that even though I'm going to be talking about some of the specific elements of what makes up PTSD, a lot of people may experience some of these and not necessarily have post-traumatic stress disorder, but are still being affected in a pretty substantial way by some of these symptoms. And as you heard on the video, this is quite prevalent. And you know, one of the issues is that, first of all, there has to be a definition of a trauma. And so in order to have post-traumatic stress disorder, you have to have experienced or witnessed some kind of actual threat to yourself or to somebody else, or serious injury. And then your response has to involve an intense reaction, essentially fear, hopelessness, helplessness, and horror. And so a lot of time, for most people, there's a physiological reaction that's going on, as well as a psychological reaction. So let's say somebody was in a car accident, and they really don't have any memory of it. It would be unlikely that that would be considered a trauma that might trigger post-traumatic stress disorder, because they don't have number two. They don't have memory of that. And that's true for a fair number of our individuals who have traumatic brain injury. They really don't have any memory of what happened to them. Sometimes there's retrograde amnesia, as well as you know, amnesia of the event, and so they don't even remember what was going on leading up to the event. So, you know, we know that when we study people who are exposed to trauma, whether it's combat trauma or it's people who work in emergency situations, firemen, first responders, people who've been in natural disasters, hurricanes, tornadoes, and so forth, about a third of people consistently will develop PTSD, which means most people don't. And so sometimes we think of this, PTSD, as really a disorder of non-recovery. And we don't know exactly. Why is it that some people seem to develop these symptoms and they continue over time? And other people have symptoms. Most people have immediate symptoms, but over a couple of days and weeks, they start to resolve. We don't know. Like I said, it's possible there's some genetic predisposition, potentially. Sometimes prior history really plays into it. If there have been other traumas in somebody's life, there could be an environmental component, it's believed, or probably some combination of all of these. Kind of an interesting thing that is going on at Walter Reed right now, and that is where they have a very large rehab facility there for people who have amputations, and particularly multiple amputations. And there is a large group of people who are in rehab there who work out in the gym, and they work with a lot of physical therapists and kinesiotherapists, and they really get a lot of rehab and support. And it has been hypothesized that that group, even though they have these incredibly traumatic injuries and have had very traumatic experiences, seem to have a lower rate of PTSD. And so there are some studies of this that are currently going on, but it's believed that because they come back, they have a lot of support. They're in a situation where a lot of people are coming through there and they're kind of telling their story and processing it. The family is supportive, the military is supportive. They have opportunities to do things and kind of have some meaning in their life again. A lot of times they will speak to other people after they've had more recovery. And so it's believed that these various things that happen in their environment are protective in some way from them developing PTSD. So another important symptom of PTSD is this idea of re-experiencing. And kind of the hallmark of that, and I think what people tend to think of when they think of re-experiencing, is the idea of flashbacks. I'm sure some of your literature had experiences of flashbacks in them. And so that can be a situation where somebody really, in the moment, doesn't really know where they are. They're dissociating. Sometimes I tend to think that nightmares kind of constitute this re-experiencing as well. Sometimes it's more psychological distress when they're in a situation that reminds them of the trauma. So it's a trigger, and they have all those same feelings that they had at the time that the traumatic event occurred. Same thing for physiological reactions. So it might be that somebody wakes up in the middle of the night and their heart is pounding and they're sweating, you know, they're all amped up, and they don't necessarily remember what they were dreaming, but they're having this physiological reaction. Another really hallmark symptom for PTSD is avoidance, and I'm sure that you've heard a lot about that, and I'm sure Dr. Campbell talked about that. But that's this idea, makes sense. I mean, of course, you're going to want to avoid things that remind you of the trauma when it's painful. And so any effort to avoid activities that remind you of the trauma or there are situations that are similar are constituting this avoidance. Sometimes people will not have memory of parts of the trauma. And it isn't because they had a head injury. I mean, that would be a different situation. Sometimes people have diminished interest in activities that they used to enjoy. I've had so many of the active duty service members say, you know, and veterans too, they've just lost interest in hunting. Not interested in that anymore. It's too much like what they experienced when they were deployed. Sometimes avoidance is detaching from others, just not feeling like you really trust people, you just really don't want to say much to people, and sometimes that also plays out in feeling kind of indifferent. Another kind of interesting feature for people that I think also kind of plays into this avoidance is this idea of a foreshortened future. And, you know, oftentimes in talking with some of these younger guys who and women who are your age really can't even envision what it's going to be like to be 30. They just can't imagine that they're going to live that long. And frequently will say, yeah, I just can't imagine making it to 30. Increased arousal is another symptom, and so you heard quite a bit about this on the video. This idea of having irritability or feeling very hypervigilant, can't really relax, having trouble sleeping, having trouble concentrating. I was working with a guy who, you know, oh no, I don't have PTSD, I'm fine. Was telling me about how he took his family out and he had such a hard time driving them over to Target. He said, because, you know, I'm like all that garbage on the side of the road, I'm so focused on it. I mean, because his job when he was in Afghanistan was to constantly be sweeping and watching for potential IEDs that were, you know, buried in trash. And so he just, it was impossible for him not to continue to do that, even, you know, months, and I think for him it had been like a year later. Exaggerated startle response is another example of increased arousal. And my office is, I have a door on my office, but then there are some swinging doors to our unit right outside of my office. And, you know, so many individuals that I'm working with, even though they know those doors are there, when they hear somebody walking through it, you know, they're looking every time. And, you know, oftentimes they'll apologize. Oh yeah, it's the door. But, you know, their startle response, it's so ingrained that even though they know that that door is there, they still respond. Also, the duration has to be for more than a month. So again, if people are having these symptoms early on, that would be considered an acute stress reaction. That is something that is relatively common and expected. But for something to actually be PTSD, it has to last, these symptoms have to last longer. If it's less than 3 months, it's considered acute. If it's more than 3 months, it would be considered chronic. And then sometimes people have a delayed onset. I don't know if that cropped up anywhere in the literature that you were reading, but people maybe didn't have this reaction until a little bit later, at least 6 months later. And typically there is another trauma that triggers that. This is relatively uncommon. And then again, the effect, there has to be some negative outcome. Impairment in their social functioning, occupational functioning, or some other important area of functioning. And so I wanted to just real quickly mention this concept of avoidance again, because it is certainly believed by practitioners like myself that avoidance is one of those things that keeps this chronic stress reaction, PTSD, whatever you want to call it, going. And because we know avoidance is really negative reinforcement. And for any of you who have had some psychology classes, you know that negative reinforcement can be very powerful. So basically what happens, let's say somebody goes into Walmart and it's a very anxiety-producing situation for them. And so they're feeling overwhelmed, they leave. when they leave, their anxiety goes down. So they are reinforced for leaving. And so this is a cycle that is going to perpetuate itself. And so the individual, over time doesn't go to Walmart anymore, doesn't go to any other kind of place where there are crowds anymore. And so that would be fine if it wasn't a problem, but oftentimes for people when their life starts to narrow down like that, it really affects their functioning, it affects their relationships, it affects just their ability to really function fully in the world because their life becomes so small. And so this avoidance is kind of dictating everything that they do. Lots of different ways people might avoid, withdrawing, leaving a place, isolating. Sometimes irritability is seen as avoidance. It's really a way to kind of keep people away from you. Substance abuse is another way of avoiding. A lot of times people will also use substances as a way to sleep. Certainly there is avoidance in relationships, intimacy, particularly with people who've had sexual trauma. Another way that is kind of a more unusual way that people might avoid is by not putting themselves in any situation where they're going to be singled out. So making sure they do everything just perfectly right, not being in the spotlight. So this kind of leads me to the concept of treating PTSD. And these words probably do not have a lot of meaning for you, but what has happened really since the era of Vietnam in trying to help individuals who have PTSD or have even some of these symptoms is that a number of different therapies have been tried. And there are some now that are considered evidence-based, meaning that in studies and trials where they compare one approach that you might use to another approach, they're found to be effective. And these are various therapies that we utilize at the VA to try to help people who have PTSD. The two kind of main approaches that we're trying to do in these therapies, and hopefully this will make sense to you as I've been talking a little bit about what kind of constitutes PTSD, is one is what we call exposure-based therapy, and that's what cognitive processing therapy is and prolonged exposure. This idea of in a safe environment, starting to be exposing yourself to those situations that you've been avoiding, sometimes for years. And so working on changing that whole negative reinforcement paradigm that I just spoke of is part of what we try to do. The other piece is really trying to work on people's cognitions. And this probably is something that you have read about, this idea that a lot of times when people have been exposed to a trauma and they're having a difficult time with it, often have very faulty cognitions. And so, for example, somebody that I worked with had been a driver in a truck that had been hit in Afghanistan, and he was very seriously injured. Several people were killed, other people were seriously injured. And one of his last memories before they got hit was of laughing. And he was the driver. And so he started thinking that, because he had this memory of laughing, that this must have all been his fault, that he must have been screwing around, that he wasn't being serious enough. Well, in actuality, none of those things were true. It was, like in anything else. At times there's a little levity. People might laugh at times. They use a lot of gallows humor in the military. There were reports that this was not his fault, but because that was his memory, that particular cognition started to take on this life of its own. So you can imagine that what we would try to do is to really dispute some of those cognitions and help him think about that differently. I thought I'd just give a real quick example. This is somebody who is a Vietnam veteran who we did what is called prolonged exposure with this individual. So he was somebody who had been in Vietnam, and his criterion index trauma was that although he had been exposed to a lot of very traumatic experiences, one that really stuck in his mind was this experience where he had to crawl through this tunnel, and they thought that there were going to be explosives or something in there, but he was alone in this tunnel, and it was a very long tunnel, and he was in there for what seemed to him like, you know, several hours. He eventually came to a clearing, and in the clearing was this Vietnamese patient, and it became clear to this guy that this was like a kind of a makeshift surgery room or something. And this guy was moaning, and the veteran thought at any moment he was going to be ambushed, because if this one individual was here, there must be others hiding out. And there were other pathways that led off of this room, and this was all underground. And so he then eventually got this guy out, but at every moment he kept thinking he was going to be shot and killed. So that was his trauma. And then in terms of the re-experiencing, this was somebody who had nightmares. He had a lot of psychological and physiological distress over the course of decades. He, in terms of avoidance, he avoided any situation where he was going to feel closed in. He did not go down in his basement. He did not like to be in situations like this room, you know, where there weren't windows. And so he avoided a lot of these situations. He also had a lot of hypervigilance, you know, to sounds in particular, but also didn't feel like he could really stay in a situation like going out for dinner, unless it was a place that he was very familiar with and could sit in a certain spot. This you probably have heard of others who've had this experience. He had chronic PTSD. This was 30 years later. And in terms of the negative impact, he felt like, you know, not only had this been really difficult for him and very unpleasant and painful over the years, but it had really prevented him from doing a lot of things that he wanted to do, being involved in organizations, going out with his wife, spending time with his children or quality time with his children. Now he was a grandfather, and he said, I'm not going to do this with my grandkids. I'm going to live my life with them. And so he was very motivated to try some new treatment, and he did really well. And things changed a lot for him. He was able to, ironically, during this, power went out at his house, and one of his assignments was going down into the basement and staying down there over time. And at one point, they lost power, and he had to go down there and clean out his refrigerator. And, you know, so a lot of things kind of played into our therapy that were helpful. But this, I just give this example to show you those different elements of PTSD and how we might work on those to improve those and really help decrease the avoidance and some of the cognitions related to that. So I think with that, I'm going to stop. I know we're probably almost out of time.